If there are any questions, we will definitely be happy to answer them. But bringing the discussion further, I think we start from the right from clinical practice. I'll ask Dr. Saurabh this question whether you follow a clinical criteria in your practice to diagnose functional dyspepsia, or you go by the Rome criteria. That's question number one. And how do you decide to investigate the patient, especially endoscopy, whom to be done? This has been already covered, but just to re-emphasize, I think this question needs to be answered for the physician levels.
So the first question was diagnostic criteria, which ones I follow. So I think the clinical diagnosis of functional dyspepsia, as we sort of went through, was early satiety, having two different constellations. One is the postprandial fullness, early satiety, bloating with eructations, that phenotype. Or the other one is the postprandial epigastric syndrome type patients when there's burning and pain after eating food in the epigastric region. So those are your clinical criteria. In terms of following a strict criteria of Rome 4, I don't, because that would require 3 to 6 months of symptoms, and our patients don't fulfill those criteria 9 out of 10 times. So the diagnosis is based on the clinical presentation of the patient. Okay. With regards to the investigations, sometimes at our center, we end up having patients coming from a long distance. So we do prefer to investigate and ensure everything is okay. But if you purely look at clinically, say I have a local patient who's willing to come back in a periodic manner, I do give them a trial of PPI sometimes, or vonoprazan or something to see how they feel. If they don't have alarm symptoms, they're young people who just feel bloated after eating or having some burning, acidity is what they would term. A trial of PPIs is absolutely worth considering when it's young patients with all of these symptoms. Of course, there's no weight loss, no bleeding, no dysphagia, none of that. We give them a trial of at least 2 to 3 weeks and see how they feel. And if it goes away, there's no problem, then we're fine. However, if the patient ends up having persistent symptoms or any alarm symptoms, or age is above 40, I tend to proceed with an upper GI endoscopy. In the endoscopy, we do end up checking for Helicobacter pylori. The number needed to treat, which implies how many patients treated for H. pylori will actually make a difference to their ultimate clinical result, is not very, very small. So there are about, I think in NNT is about 8, which means you find H. pylori, you treat 8 patients, one will get benefit, others may not. So H. pylori being a very rampant organism can lead to symptoms. So it is not always correlation. That's how I put it. But when a patient with dyspepsia has Helicobacter pylori, yes, we are compelled to treat it and see if that helps the symptoms. But I always keep in the back of my mind any other possible issues that the patient has, that could be psychiatric problems, and stress, anxiety. And it's very important that those things should be addressed in parallel to just treatment with, say, H. pylori presence. Of course, in another scenario, if there are ulcers and there is significant inflammation, then you're compelled to believe that the treatment will be more effective, which is acid suppression and H. pylori treatment. Other testing like gastric accommodation is not frankly available. Some things which we do in our unit are breath test for bacterial overgrowth. We can do lactose intolerance breath test, although it's a clinical diagnosis. Checking for celiac disease, which can be serology or duodenal biopsy based. So those are some of the other things that you can additionally do to rule out an organic condition. And most importantly, if the patient has weight loss or major alarm symptoms, vomiting, a CT abdomen should be considered in addition to your standard.
Thank you, Dr. Saurabh. Basically, I think the symptoms has to be bothersome, because the word bothersome is very important, because it has been stressed in the Rome criteria that bothersome symptoms, bothersome fullness, bothersome burning. So one thing is troubling to the symptom. patient. Number two, it should be chronic. I mean, it should not be, say, for example, 8 or 10 days, we label it as functional dyspepsia. So it has to be chronic. So chronic, bothersome, and no organic disease. So these three things have to be kept in mind when you, and as emphasize the elderly person, short history of dyspepsia, alarm symptoms, weight loss, anemia. Those all are the things where the physician should not treat them and refer for investigation to the gastroenterologist. Now, many of these patients, they would have burning, they would have fullness of abdomen, and they would have altered bowels, which is a combination. You don't get a stereotype symptoms when the patient comes to you. So, how do we differentiate from GERD, from IBS, that how do we differentiate functional dyspepsia from gastroesophageal reflux disease or IBS?
So I think that can be sometimes challenging. You see, these patients uh, have visceral hypersensitivity oftentimes, and there is a certain degree of overlap in having presence of dyspepsia with IBS in the same patient. And oftentimes you will have patients with reflux and dyspepsia at the same time. So what I'll do tend to focus on more is what exact symptoms that the patient has, which seems to be more bothersome or more pronounced. And sometimes it's more reflux predominant. They may have a little bit of gastric burning, but their more predominant symptoms is heartburn and regurgitation. On the flip side, they may have a little bit of regurgitation, but have most postprandial burning and abdominal pain. Now, it's important to do that differentiation because sometimes patients are referred for endoscopic anti-reflux therapies and stuff, and then you realize that they actually have more dyspepsia. And, treating them with an endoscopic procedure may not be beneficial because their symptoms will not go away with that. So some things are very important to differentiate between the two. IBS, yes, the lower GI symptoms, again, not very easy to differentiate necessarily. But that can be a bit of an overlap. They may have some cramps, some bloating, some discomfort, along with them some change in stool frequency. So we end up having to treat, a combination of both oftentimes, where we find and understand the exact symptoms and treat accordingly.
So predominant heartburn and regurgitation, if that's a symptomatology, then it's probably more of gastroesophageal reflux disease. And if there is a predominant lower abdomen and altered bowels, then probably it is more like IBS. Now, gastric dysmotility has also been seen in about 20 to 30% patients of functional dyspepsia. So, how do you differentiate it from diabetic gastroparesis clinically? Sometimes, many of these patients are diabetic and they come with dyspeptic symptoms. So, what are the clinical parameters which will tell us that this is gastroparesis and not functional dyspepsia?
See, when it comes to gastroparesis, the symptom pattern is going to overlap with functional dyspepsia. So something in which will be more suggestive of gastroparesis is something more in terms of predominant vomiting. Some patients, not many, they may complain of vomiting food that they, ate in the morning, in the evening, or something that they ate yesterday, they're vomiting next morning. So, which would imply that the stomach is really slowed down, the food is not going across the pylorus, and that goes more in favor of gastroparesis. So there will be some overlap. Now, stomach fullness is something that both the symptom, both patients would have. Not ability to finish meals or feeling very full, loss of appetite, bloating. So these are things that can be seen in both conditions, and there is no way to differentiate clinically based on that. but something more in favor of vomiting, fullness, no pain. They generally would not experience pain or discomfort. More, it's more vomiting and old food and retching, and these would be more gastroparesis. Dyspepsia, on the other hand, would not have that much vomiting. That's what I would say. Yeah.
So vomiting, I think, is a predominant symptom. Presence of vomiting goes in favor of gastroparesis, and the fullness and others will be common to both, but presence of vomiting is a very important symptom. Now, I'll ask Shubhankar. So, when the patient with functional dyspepsia comes to you, would you start the combination therapy of PPI, promotility, or would you find out whether the patient has H. pylori and treat accordingly?
As we discussed, so functional dyspepsia is labeled when the patient is not found to have any other confounding etiology. The most common ones are H. pylori, NSAID use, and few are gastric dysmotility disorders. So initially, it is recommended that whenever the patient presents with functional dyspepsia symptoms, we should ideally test him for H. pylori for all the patients. But what we practically do is we first give a trial of PPI. Of course, it is not possible in every patient to test because of some cost issues, but it is ideal to test everybody. Then second problem comes when the patient is coming to us from far away. Because the guidelines say that whenever a patient comes to you, you should test him for H. pylori. If you find H. pylori, you should treat it first. Then you should give a course of PPI. If the patient is not having H. pylori infection, you should give him a course of PPI and then call him after 2 to 4 weeks. But unfortunately, the patients stay far away. So we end up not following them for at least 2 or 3 months. In that case, what we generally prefer, of course, at our center, we have the H. pylori breath test, which is very easily available. So we should ideally test them first. If the patient, of course, has cost issues, we should give them a trial of PPI, call him after 1 month, ideally. If there is no response to PPI even after 1 month, we should add prokinetic agent, and that should be continued for 3 months before doing any other thing.
So basically, if the now you have two types of categories: epigastric pain syndrome and postprandial distress. Earlier, there was a concept that the PPI were given for epigastric pain syndrome. So that means whenever you have symptoms like acid peptic disease, like epigastric burning pain, more on empty stomach, better with food, and those sort of symptoms, those are defined as epigastric pain syndrome, and the fullness, satiety, heaviness of abdomen are defined as postprandial distress syndrome. So, epigastric pain syndrome, PPI. Postprandial distress syndrome, promotility drug. But then there was a concept that PPI also work for the postprandial distress syndrome. Is there any evidence that the promotility drugs also work for epigastric pain syndrome?
Sir,
The other
for
way.
epigastric pain syndrome, the data is actually limited. They do have a benefit in symptoms, epigastric pain, postprandial distress, and early satiety. All the three are improved, but the ones which are most improved are early satiety and postprandial discomfort.
Sometimes it is difficult to differentiate also clinically between this. In your practice, would you use PPI or PCAPs? Is there any data to suggest that PCAPs are better than PPI in functional dyspepsia?
There is data, sir. The approved use till now is, of course, in erosive esophagitis and H. pylori eradication. But functional dyspepsia symptoms are like they improve better with PCABs than PPI, possibly because of sustained acid suppression. So I would nowadays, actually, most of us have actually switched to PCAB rather than PPI as an initial treatment option.
And what is the long-term natural history of functional dyspepsia? Because the
Hmm.
trials have shown that it has to be given for a period of a year or so. So,
Hmm.
I mean, what is the long-term history for functional natural history, one would ask?
I'm not very aware, sir, what is the natural history, but it depends on the etiology. If there is post-infectious dyspepsia, if there is post-H. pylori, H. pylori dyspepsia, it will of course improve after a certain period of time. Whereas the etiology is unknown, it is likely to be multifactorial related to the dysfunction of pacemaker cells, which of course have a lot of overlap with gastroparesis symptoms and which causes severe dyspepsia even at the beginning. So these patients are less likely to improve even in the long term. But I'm not fully aware of the natural history of functional dyspepsia. If there are any long-term studies, environmental studies, I don't know.
Yeah, I think about 30 to 40% patients, they have a recurrent disease. And about one third of the patient, they possibly land up in remission. So, of course, because the ecoshiamide was given for long. And would you advise, in which conditions would you advise ecoshiamide as a treatment of choice over the other promotility drugs? Because cisapride is banned because of cardiac problems. Perinorm metoclopramide has serious side effects, oculogoic crisis, it crosses blood-brain barrier. Domperidone also is associated with some arrhythmias. Etopride, whatever preliminary evidence for functional dyspepsia is not better than placebo. So you are basically left with very few drugs as a promotility drugs.
Yes.
So where would you say that over Mosapride? Because I don't think there are many trials of Mosapride and other things in functional dyspepsia.
No, I'm not
So
actually
I
aware.
think it's amongst the promotility drug. It is, and Lesuride, you already commented that it is associated with
Significant
CNS side
extrapyramidal.
effects, extrapyramidal CNS side effects. So acoshiamide, where would you put it as a drug according to you?
So the 4 or 5 major drugs that we have for uh, in India, uh, icosiamide, levosulpride, etopride, long-term metoclopramide or domperidone, we generally tend to not give. Levosulpride, of course, has a lot of extrapyramidal side effects. Mainly, it is the drugs which are considered more safe are icosiamide and etopride. So the choice eventually comes between these two. I generally prefer icosiamide in, especially in the patients who have a background of diabetes because they have some or the other gastric dysmotility present. The patients who have predominant postprandial distress symptoms, I generally prefer icosiamide, or the ones who are slightly younger, although there has been safety data, but the two trials which I showed, patients with extreme cardiac comorbidities are actually excluded. So I tend not to give icosiamide, especially for long term in the patients who have background cardiac disease. The young patients may be diabetic who have predominant postprandial distress syndrome symptoms generally start with icosiamide first.
Okay. And how long you give?
I generally give for 3 months because if we write, maybe most of the patients we can continue for 6 months to 1 year also. But the initial treatment, what I tell to the patients is at least for 3 months.
Would you prefer a single dose like OD, sustained release over
Yes, sir, definitely.
three
Because
times
it,
because the compliance issue
yes,
is
sir.
there?
Yes, sir. 3 times dosing becomes very difficult for the patients and they generally don't comply with the adequate
Yeah,
doses.
that's there. So I feel that especially in this especially patients who have early satiety. Those are the
Yes.
ones who will be benefited apart from postprandial distress syndrome because
Yes.
it improves the
Understood.
gastric accommodation. So, so that is a one entity where I think it should be definitely
Yes.
stressed.
Yes, sir.
There are some questions. I'll just finish off the how long should echo gut should be given? That I think is on answer. You have a safety data for a period of 1 year. Normally, about 8 to 12 weeks is the first therapy. The patient has recurrent symptoms you can give. How should one start with a combination of drugs with ecoshimide in which conditions? I think that also has been answered. Normally, in clinical practice, you have to find out what is the history of the patient and what drugs he's on. Suppose if the patient has already taken PPI and he's come to you and he's not responding, the first thing I would find out is to rule out organic disease, to find out about H. pylori, and then, start a combination of drugs rather than PPI or PCAB alone. So combination of drugs, and I don't think there is any comparative data between PCAPs and PPI for treatment of functional dyspepsia. However, the efficacy of PCAP H. pylori treatment is beyond doubt more than the PPI treatment. Then there is a question from Dr. Manoj Kore. Any change in functional dyspepsia presentation trend over the years, perhaps due to dietary habits, H. pylori prevalence, or stress level?
I think, sir, you must be the most appropriate person for this.
I don't think that there is any changes in functional dyspepsia, but the prevalence is very high. That I would definitely say that whatever patients we used to see earlier and now, the number of patients with functional dyspepsia are definitely more. And as you rightly said, that stress level is a very important factor. I don't know whether there are statistics of H. pylori prevalence. There are any comparative studies which are done over a period of years. But improving hygiene as India is going towards might reduce the incidence. But again, it's a combination of factors where stress, dietary habits, we're going more to the Western diet, more eating spicy things, possibly can be one of the factors. Role of screening for food intolerance and dietary triggers, and how useful is dietary modification and real world practice.
So the lifestyle changes remain a very important tool in managing the patients of functional dyspepsia. We generally start the patients on small, frequent meals and fat-restricted diet. Basically, high-fat diet increases the gastric time of the food and results in delayed gastric decompression. So having low-fat meals actually promotes gastric emptying and it results in better symptom relief. Apart from these, I'm not aware of anything which has been shown to have a certain amount of benefit.
Yeah, actually, normally we ask our patients to have low FODMAP diet, which is very important. FODMAP, the concept of FODMAP is fermentable oligodisaccharides, monosaccharides, and polyols. So, in shorter words, I can say that any diet which is having high in carbohydrate can give rise to more of dyspeptic symptoms. So, if you go to the net, you will find that what is high FODMAP and low FODMAP, and you can advise low FODMAP diet for your patients. Some people may be, as Shubhankar has said, the oily foods, fatty foods should be avoided. I would also go with the milk and milk products, and some patients gluten has to be avoided because that can be a gluten sensitivity, not exactly celiac disease, can be one of the factors for them. But there are no specific foodstuffs except for those which we have enumerated, which we should be, because it's a combination of factors which are there, more gut sensitivity and other things. The last question: what is the difference between the three PCAPs, vonoprazan, pexuprazan, and tegoprazan?
Maybe only in terms of duration of action and slight difference in the efficacy. But apart from that, they are as a class, they are more or less similar.
Yeah, they are most effective, acting even if on the patient is taking the drug on without empty stomach after food also, because they can act on all the proton pumps without activating them. So taking on empty stomach is not necessary. They have a long term action, except that the vonoprazan acts, say, within 6 hours. Probably this fexuprazan and the uh, tegoprazan acts more faster. And the major advantage is regarding the drug interaction. But I don't think that there are any trials of efficacy comparing the three PCAPs. Neither there are trials in H. pylori also regarding the three. The efficacy wise, they are more or less same at, at the end of therapy. But onset of action and the rapid relief is more with fexuprazan and tegoprazan as compared to vonoprazan. And the drug interaction is less with fexuprazan and tegoprazan as compared to vonoprazan.